Do you have a medical power of attorney or
Yes.
advance directives?
Yes.
Okay, perfect. Are they on the chart or do you have them?
I have them. I don't know if they're on the chart, but I have them.
Okay, I'll just let you send it to them.
Okay.
So anyways, kind of what he asked us to do is just talk to y'all about, future planning. So in her advance directives, does she want to continue like aggressive treatment to a certain point? What is she wanting as far as like, is she a DNR yet? Okay. So, hi. She's just saying 87 to 85. Anyways, so I know that they found new lesions in the lung and everything else, and they've told you all of that, right? Mm-hmm. Okay. And just so I make sure that you understand everything, tell me kind of what brought her to the hospital.
Well, she has a cirrhosis of the liver and then the cancer in the liver as well. She was throwing up. She had been, I think this is probably the 5th time this year that we've been in the hospital.
For vomiting?
Yeah, for her being confused because her ammonia levels get too high.
Okay.
And then she was throwing up, and so we brought her in, and that's when they let us know, about her kidneys.
The kidneys are, and so the kidneys are kind of not functioning right. And then they did the EGD, found some an ulcer and everything that had been bleeding but wasn't, and then some. Okay, and then so basically, what have they said as far as like oncology? Are they offering further treatment or?
Well, she still takes a chemo pill, Lenvima, every day, but Dr. Martinez has pretty much kind of said that he's following the lead of whatever the kidney doctors are saying in general.
Right, and she's still able to take that with her kidney function, or have they had to stop the?
No, as far as I know, they're still giving it to her.
Okay, awesome. And then so from this point forward, kind of what is? I know that I looked in the chart and they had talked about going home with home health. So the choices are continue aggressive treatment in the hospital and then go home or go to a facility with home health, because right now she's a lot of care for just you.
Right.
So she would need to have some kind of rehab, like get stronger and everything if she's able to.
Right.
But if she's not, like if she's not progressing or not able to do that, the next steps would be, would y'all want to do like hospice? Okay.
Yeah. I think so. We had talked about going into a rehab after this, but Dr. T said earlier that it probably wouldn't be beneficial for her because the rehab part requires some activities during.
Yeah. So rehab requires like 3 hours of physical therapy a day. Mm-hmm. So then the second option is like a skilled nursing unit, and it's about 30 minutes of physical therapy and then kind of trying to see if they get stronger. But if it doesn't look like she's able to even progress and participate in that, then we have a palliative care unit here. And it doesn't mean you have to. I talked to Dr. Traftar just a little bit ago. So we could transfer her to our unit as a med-surg patient, continue all care and see if she could get a little bit better and go to the facility with some rehab to a skilled nursing facility with rehab, or we can transfer to our unit for hospice, kind of starting hospice care. And that means you withdraw all aggressive treatment. So all the IV antibiotics, the IV fluids, all medications other than, like if she needed medication to keep her blood pressure down, like high blood pressure, if she had seizures or something like that, we want her to be comfortable. Right. So we're not going to stop those kind of things. Right. But like chemotherapy, antibiotics, all the other stuff, we stop that. We do what's called comfort feeds. So if she's thirsty and she wants to drink or eat anything, then we provide trays and she's able to do that. And then if she's what we call stable at bad in about 2 to 3 days, then case management will start working with the family on placement, probably in a facility, unless someone's able to be with her 24 hours a day, and then go home with hospice or to a facility with hospice. So what hospice looks like is there's a nurse that comes once a week, and as they get closer to passing, they come more frequently. They have caregivers that come at least a couple of times a week to bathe her and change her. Even if she goes to a facility, they still come and do those things.
Okay.
There are a second set of eyes and hands and everything. If she were to go home, and for comfort care on our unit, and then went home with hospice too, we use a couple of different medications. So with renal function being down, we would use a medication called OxyFast. It's a concentrated oxycodone. You just put it in the cheek and it's absorbed there. They don't have to swallow a pill and let it dissolve and be absorbed. We also can use IV medications if we need to help with management. So the pain medicines have a couple of different functions. They help with pain, but they also help with breathing. So if they're kind of struggling to breathe or, working hard to breathe, those medications help her to relax, her body to relax, and not have to work so hard to breathe. And then that can be given every hour as needed. And then if that dose isn't enough, after a few hours, if she requires medication like 3 hours in a row, then we go up a little bit on medication. We can also give it IV in the hospital. At home, they won't be able to do IV,
Right.
but or at a facility.
Right.
So, I'm so sorry. This is so hard. God bless you. And then use another medication called an anxiolytic for anxiety, like Valium or Ativan. And so Ativan is made into a liquid and it's real concentrated. Same thing, kind of goes in the cheek or under the tongue so that it's absorbed by the mucosa and then absorbed into the bloodstream pretty quickly, and helps manage restlessness, anxiety, especially some patients, if they're struggling to breathe or anything, the pain medicine helps, and then the anxiety medicine helps. And that's every couple of hours.
Anxious today, so.
And restless,
Yes.
Yes. And so it helps with that as well. And then we, as patients are less alert and not really swallowing like they normally would, are you sliding down? Then the secretions in your mouth, that when that part of the brain kind of stops working, the secretions kind of can build up in their mouth. So we use a scopolamine patch. We put it behind the ear. That kind of helps dry out the secretions. We use some atropine drops in the mouth, kind of help dry out secretions so they're not breathing like really wet, like you feel like they're going to choke and gurgle. Yeah,
Right.
Exactly. Some patients, it doesn't matter how much medicine we give them, they just produce more saliva and kind of sound loud. And that's very distressing for the family most of the time, more than it is for the patient. They do suction as needed, but just like in the mouth, we don't do deep suctioning, because once you start doing deep suctioning, if stuff is kind of back there, then what you're doing is kind of traumatizing everything, and it just causes our body to produce more. And then if we cause enough trauma and they start bleeding, then that's even, they're choking more, and it's
Right.
it's just hard. So, if we have to, we'll suction a little bit in the mouth, but we don't do deep suctioning just because it creates, more secretions, and it just is a vicious cycle, and then it turns into something that's not good. The patients have Foley catheters and stuff like that. On our unit, anybody can visit from newborn to whatever age. We don't have an age limit on the palliative care floor. Family is welcome to stay. There's one of these little couches in each room, and I think there's a recliner too. So, and they'll also provide a meal tray for whoever's with them. What? And so she did the Y90. Did she do it at UMC?
No, she
Or did it here?
Mhm.
Okay.
Yes.
Okay. I used to work in interventional radiology several years ago when I was a nurse, before I became a nurse practitioner, and that we did a lot of those over there, and they actually didn't do them here, but now it's been several years, so anyways.
Yeah.
So just kind of, and you don't have to make any decisions right now. If you want to, if you're comfortable with just moving her to our unit and continuing all care to kind of see how she does, I don't foresee that, and I could be completely wrong just by reading all of her records and stuff. I don't know that she would be able to participate even in 30 minutes of physical therapy each day. And I don't know that she's going to get stronger, but I'm not counting anybody out. So.
Well, she was just up. Physical therapy had her up.
Oh, good.
Yeah, Tuesday. So, and she keeps wanting to stand up today. She was kicking her leg over the side of the bed.
She's like, I'm getting out of this bed.
Yeah. So, yeah.
So what are your thoughts? Yeah. Just.
Well, I went through it with my dad, so I understand what palliative care is. They didn't have a floor here, so we ended up going home back to Snyder. So I do understand everything and all of the care. It's just trying to figure out
what's the
exactly.
Right thing. Yeah.
Yeah.
She's still a little confused. So.
Yeah.
She's like, I'm trying to.
If your finger, okay?
If we say we went to palliative care and were there for a couple of days and did notice that she wasn't able to participate with the PT, would we then be able to transition to hospice
to comfort,
at home?
Yeah, comfort care, and then we work on hospice at home.
Okay.
So, yeah, that's perfectly fine. And that was kind of what Dr. Traftar said. I'd rather her go over to your unit, and that way, if she is not able to do what we're hoping, then she'll be there, and it'll be an easier transition and everything. I know that physical therapy doesn't usually come over the weekend very much. So, maybe by early next week.
Oh.
She does. She's like, I'm done with that.
Yeah.
Okay. We're still waiting for the other bag, so we'll.
And so, yeah. And if, we get over there and early next week, if she continues to decline and her renal function isn't really getting better and we don't foresee things getting better, then we can have a different conversation and just kind of go from there.
Okay.
Does that sound okay?
That does, yeah. I think that was my concern. I feel like once I make a decision or a choice, it's kind of stuck that way, but...
And it really isn't, but the beauty of just moving over there, because we do have some med-surg beds, the beauty of moving over there is she could go go to a facility with skilled nursing facility, and then hopefully transition home with home health. That can be the goal. But sometimes if she's not making the progression, and especially if her kidneys don't work like they need to, and all right, thank you. And also she's declining a little bit because she's requiring a little bit of oxygen.
Yeah.
And so, if that gives her a little time just to kind of see how she's going to do and how she's going to progress, and then you can feel more comfortable about any decisions you make. But also, if she has a advance directive, then I know even as a family member and they're asking what our decision is, you just have to remember too, you're not really making those decisions for her. You're honoring the decision that she's already put in writing that she wants.
Yeah, I think that's what's hard.
I know. I can't imagine. I've been through this with my dad, but if it were my mom, I don't think I would not be well. I would be unwell too, so I would be.
Yeah, I didn't realize until this year that that's what she wanted. So it's making sure that she gets what she wants, but also, she's comfortable.
Yeah, exactly. Okay, so I will put in the transfer orders to transfer, or I'll tell Dr. Traftar to go ahead and put in the transfer orders to transfer to our unit.
Okay.
And then we will follow up with y'all like Monday or Tuesday and kind of see. We'll follow up with you Monday, kind of see how things are going.
Okay.
She may or may not have an opportunity to work with physical therapy before we see her, but we can kind of just see how she's doing.
Yeah.
We'll know kind of how her kidneys are functioning, if she's requiring more oxygen, if she's having any other decline, then we would be able to look back at all of that and then have a conversation.
Okay.
And if she's looking like she's still progressing and hopefully getting towards discharge, then we'll just keep doing everything that way.
Okay.
Does that make sense?
Yes.
Is that doable for you?
Yeah.
Okay.
She's got the willpower. It's just her little body.
I know.
It's just been through a lot, so.
It has.
Still going currently through a lot, so.
Yeah, exactly. But she's not throwing up anymore or anything?
No, not today. She had
Good.
a little bit of dry heave earlier, but.
But that seems to be better. Is she taking any clear liquids or anything?
Yeah, she was drinking
Good.
earlier. Yeah.
Good.
She actually been up and restless all night long. She's finally to where
Trying to relax.
she's, yeah.
But what I can do, I can add some medications to help with anxiety. I can add some IV medication, and that way Valium, or I can add oral, the one or the other, and she can have that like every 4 hours or so as needed.
I think that would help because she was very fidgety last night. So, yeah.
So then I'll put that order in every 4 hours as needed, and definitely you can ask the nurse, say, can you please give her something tonight before she goes to sleep, her anxiety medicine, so maybe she'll get some more rest and she'll do better. As far as pain, is she complaining of any pain anywhere?
Yes, she is, and it's kind of a little cycle we've been going through. She'll hurt really bad, but her idea or mentality behind it is she doesn't want to get addicted to pain meds.
Aww,
so
God bless her.
She's just kind of been suffering through it and saying maybe tomorrow it'll be better, maybe tomorrow. So we've only been able to convince her just recently, the last couple of days, because
to take a little bit of fentanyl.
Well, no, the fentanyl was just today, but her pain level got higher. She actually said last night when she was a little confused that it was at an 8. So
sweet girl.
It's probably been at that, for a while.
Yeah. I like to use Dilaudid. I feel like it lasts a little bit longer than fentanyl. So I may change it to that. I'll kind of look and see what she's had and what she's used to kind of come up with a dose, and then put some orders in so that she can have that too. And then if she needs Oxyfast, Oxyfast, I don't think Oxyfast tastes bad. I think it's the Ativan and Tensol that tastes bad.
Okay.
So, especially if she's nauseated, I don't want to give anything like that.
Yeah.
But I will put in both. I'll put orders in for IV medication, and then I'll put in orders for oral medication.
Okay.
So that way she has both. Especially, I'd hate for her get the oral medication and then it makes her nauseated and throw up and everything, and then it's not effective. But then if we have an IV dose, and then we can just kind of go from there. And that will just kind of help with pain.
One of her other reasons she didn't want to take pain medicine through the IV because she didn't want it to upset her stomach. So.
Well, the good thing about Dilaudid, so morphine does more. Fentanyl doesn't really very much, and neither does Dilaudid. And it seems I like Dilaudid better because it has fewer side effects. It's a little bit stronger. Fentanyl is pretty strong too. But I think the Dilaudid lasts longer too when you get it in the IV than the fentanyl does. And so from our patients that, I take care of, it seems to be more effective, especially for cancer pain and everything else. And so we definitely want her to be comfortable.
Yes.
Okay. And then if at some point y'all decide to go comfort measures, if her pain is really bad, if she's not comfort, then we're not as aggressive with pain medicine when they're completely comfort, and we give the smallest dose available, and we do it every hour, but there's also a risk of them getting some respiratory depression and everything else if we're giving it more frequently. So the dose I'm going to order is going to be safe to get every 3 or 4 hours as needed. And so that's going to be fine for her. But just know that when they go comfort, we escalate how often they can have the medication. It's usually the same dose, but they can have it more frequently.
Okay.
But we also don't schedule medication every hour because everybody metabolizes medication differently. And our goal is to keep them as awake and alert and interactive with their family as possible, but also controlling their pain or their, dyspnea and everything, or anxiety, without making them too sleepy so that they can't really interact.
Right.
And if you just give a patient medicine every hour, then you're at risk of overdosing them, and that's not our goal. So even as a comfort patient, we do as needed every hour. And if, like I talked about, if 3 hours in a row she's needing a dose of that medicine, then we're like, okay, we know that she needs more. So the next hour we increase the dose a little bit, but we do it very slowly. We can never hasten death. We can never give high doses of medicine to help them pass sooner. Our goal is just to keep them comfortable, give them small doses that will help manage their pain, their dyspnea, their anxiety, but it may make them a little bit sleepy. And so that's kind of how we do it. And then, of course, if your dad was on hospice, as they're getting closer to death, they're less alert and oriented and everything.
Right.
And so that in itself, it's not necessarily medicine that's making that happen. It's just because their body's shutting down.
Right.
And that, and the brain
Oh my
shuts
gosh,
down.
I can't get this pillow right.
Where's your pillow?
Down
Is
here.
it under your bottom?
It's under my back.